So I'm with Tony Barone with, is it Emergility? What is
E-
the correct pronunciation?
Emergility, yes.
Almost got it right. So you're doing something fascinating. You're providing, as part of your services, concierge, community paramedicine, mobile integrated health. It's a very interesting concept. Many of the students that are watching this were in the high performance class last semester, and we talked about community paramedicine and mobile integrated health was basically focused on 911 or hospital-based services. So how does this concierge service work with you and the clients?
Yeah, so I mean, I will kind of start from I guess, a different level from what folks do know of current concierge, or I should say, mobile integrated healthcare
Uh,
community medicine. And so, we look at why did we even arrive to getting mobile integrated health? It's, you arrive on scene to your 911 call, and you realize, it's an emergency for the patient, but it's not truly a life-threatening emergency.
yeah.
This may not be a STEMI, may not be a stroke, it may not be penetrating chest trauma, but there's a laceration or there's a medical emergency there that needs to be taken care of. So the options for that patient are go to the hospital, spend, exuberant amount of money on medical care, or fix the problem there. Or maybe we should just start educating this patient on when to call 911 and when not to call 911. So is there a misuse of the system? But either way, there are the whole background behind MIH and community paramedicine is trying to fill gaps in medicine, right? Why does the patient have to go to a hospital, to a doctor's office? I mean, if we think back, honestly, you and I look back, I remember when doctors did house calls. It wasn't long ago. In fact, that's what medicine really was. It wasn't until about 60 years ago where emergency medicine really started in Alexandria, Virginia. The first ER was on Duke Street. It wasn't long ago. And in emergency medicine physicians at the time were just hospital internists or family medicine doctors that needed to deal with emergencies. So emergencies were everything. So obviously, Department of Transportation, when highways were being built, started EMS, and because of trauma. Fast forward to where we are now. Now we've got people calling for medical. Well, now people are calling for medical emergencies a while back, but it's evolved significantly to the point where some in the healthcare system, or some in the community, I should say, utilize 911 systems for primary care reasons. We're not going to fix all those problems, right? People access care the way they access care, but the delivery of and the services behind the delivery of emergency services is not supposed to be for the finger lacerations or the rolled ankles, or the bumps in the heads. It's for the true life-threatening emergencies. So when we arrive on scene to a patient and we've got two options: one, refuse care, or transport to a hospital, that leaves the patient in a situation where it's like, well, I guess I have to go to the ER because there are no other options.
Yeah.
So now with community paramedicine that are 911 based, some of the gaps and challenges that you see within those systems are public EMS isn't providing private medicine and private medical coverage. So there's a very slippery slope where you start doing community paramedicine, you start calling on patients that are the frequent flyers, and now you're doing primary care stuff. So have you just become a publicly funded private mobile service for this individual? And so how do you fund that? Well, as we know right now, CMS, Medicare, Medicaid, and even insurance don't have great. In fact, some have no coverage, no reimbursement for a mobile integrated health or community paramedicine, and some that do, it's very limited. Like, you can only call once in 30 days, or we're not going to provide all the services. We'll provide some services. And so we decided, we can do better in medicine. And why is there a gap? And the reason there's no gap, reason there is a gap is, and reason that no one's really building to fill, is because people are only building EMS systems from within either the purview of 911 based or interfacility transport based, because that's where the CPT codes are for reimbursement. And so you're not going to build a business or an infrastructure if you're not going to get funded. So we thought, well, what if we could build something that was direct access? Why can't I call someone? Why can't I phone a friend at 5 p.m., 6 p.m., 7 p.m.? Because we all know doctors, we all know paramedics, but why can't I phone a friend who could then come to my house, take care of the problem, and fix it? Now, if I need to go to the ER, let's rock and roll. Let's get there.
Yeah.
But 95% of the patients I ever transported as a fire medic didn't need to go to the ER. They needed care from somewhere, best at their home, but they really didn't need to be pulled out of bed to go to an emergency room. So I'm going to pause real quick there to kind of say I dumped a lot on you there. But the biggest thing here was filling a gap, giving folks more options to access care that's not within the parameters that are even the limitations of what 911 can do. 911 is fantastic for what it does in this emergency context, but that's not why people call 911 anymore. People call 911 for things that are not truly life-threatening emergencies.
That's a great overview. Thank you so much. So, how did you get to this point? If you could explain your career arc, how did you get to here?
Yeah, so I started off 14 years old as a fire explorer, 16 years old as a police explorer, 17 years old I started EMT school.
Okay.
I was still in high school, so I actually graduated high school as an EMT, a firefighter, and as a sophomore in college. I actually went to college all full time at the same time.
Wow.
Throughout college, I was volunteering in the fire service, and then I went off to teach. I went down to South Florida, teaching occupational environmental medicine, and went back to graduate school. Started doing really interesting things that are, post 9/11, disaster medicine, tactical medicine, austere medicine, event medicine, wilderness medicine, all the things that were outside of the hospital. Now, granted, I did work in the ER for several years when I was in college, but then I was like, I don't like being in the hospital. I like being outside. I want my ER needs to be outside, needs to be a playground. That's what I want. I'm a big kid. I want my toys to get bigger. I want to be outside playing, right? And so the whole idea was, there's got to be something different here. So I started teaching tactical medicine, started doing some fun stuff. I was recruited to come up here to the National Capital Region to write some mass fatality plans, mass casualty plans through NVERS and WCOG and Northern Virginia Regional Commission back in 2009. Did that, then went back, started, as a consultant, I was working with Immigration Customs Enforcement and FBI and HHS and all these different big organizations all around security, protection, medicine. And then I went back and started volunteering again. I was in Fairfax County as a fire medic, volunteer fire chief for a short time. And I've been part of the National Disaster Medical Systems for goodness gracious since Hurricane Katrina. So for a very long time, was a safety officer in the field doing real world disaster responses, and then now I'm on what we call Region 3 IMT for mission coordination. So right here, National Capital Region, do a lot of national special security events. So I was transporting a patient one night to Alexandria Hospital, dropping off the patient. Went over to one of my buddies, now my colleague, our medical director, Dr. Benji Mafori, and I said, hey, I have this crazy idea, of like the concierge paramedic and the protective paramedic. And I said, I wrote 2 papers about this back in paramedic school. I think there's something here. He's like, let's chat about this. Let's see what's going on here. And the whole idea was, I love taking care of patients, and I love responding to 911 calls. Don't get me wrong. I love the action. I love the fun stuff. But I found myself in Northern Virginia here, right here in the National Capital Region, responding to 911 calls for folks that just did not need to go to the ER. But there was nothing we could do, and I felt helpless. I was a volunteer. I was doing 2,000 hours a year for free, loving it. But I felt really empty. Like, man, if we could bring a doctor, if we could bring a paramedic, if we could bring an advanced practice paramedic or a nurse practitioner, they just need a prescription refill. Maybe they need, they need a lab draw. They need a catheter that needs to be flushed or replaced. Why can't we do that? And then I started digging, and it's like scope of practice here in Virginia actually allows for paramedics to do this. I can give IV antibiotics. I can do wound closures. I can change a catheter at someone's house. And it's not home care. It's a paramedicine EMS sort of purview, but no one's doing it. It's like, man, why can't we do that? Why not? And so I just started, I put pen to paper, started researching and said, you know what, I'm going to create the EMS side. But strategically, what I ended up doing, I actually created a private security service first. That led the EMS agency part of it. And that also is because there's not just the community paramedicine part. There's a huge population of people that live in the National Capital Region that do not access health care because of who they are. They can't be seen in the ER. They can't have an ambulance roll up to their house because people are taking video and pictures. And if you have a CEO or a dignitary that's seen by the public to be ill or injured, that could cause catastrophic economic damage to companies. It could be, very, very complex. It could create complex issues for countries and embassies. And so, wow, how do we do this professionally? How do we practice medicine professionally in this clandestine, covert space? Because we don't want to do it happenstance. We don't want to do it outside of being above the board. It needs to be licensed, but no one's doing this. How do we create this? So we simply went pen to paper and started throwing it together. It became a private security service in Virginia, and then followed right immediately by EMS agency. And now we're both concierge and protective paramedics and community paramedics.
Wow, that is fascinating. I had no idea. I understand, but wow, that's great. So for your clients, is there a relationship between your service and their primary care physician?
In the best case scenarios, it's always a continuum of care, making sure that everyone is communicated with and everyone's coordinated with. So we don't replace any primary care services.
Yeah.
We do not replace concierge medicine services. We don't replace 911. We don't replace ERs. We are not competition for anybody. We're not competing with anybody, because it all comes down to the patient. The patient is first, truly first. So routine medical visits, chronic care, chronic medical issues need to be managed by the primary care or concierge physician all the time. Life-threatening emergencies need to go to the ER. But what are the gap fills there? What about at 5 p.m. the concierge doctor's not doing house calls, or maybe they're too busy, but you still need to be seen. You still need a blood draw. You still need a lac repair. That's where we start filling these gaps here. The preventative and protective side. Someone says, hey, I don't really feel well. I kind of feel off. What's going on here? And we had a few of these calls that happened where we got called by another practice, said, hey, this is not your patient. We want you to go check on them. Something's wrong. Not really sure. Don't really have the indicators of truly we need to go to the ER. And we end up capturing third-degree heart block.
Oh, wow.
What? Okay. Now we're going into the ER, and now we're going quickly. And so, and this actually has happened twice. Happened just a few weeks ago as well, where we've had 2 in the field life saves where people have been told by their primary care doc, oh, you're fine. You've got a low heart rate. You're an athlete. No, you've got a heart block and you could die. And so how do we, so these things that if you don't ask and you don't look as a patient, if you're like, I don't really feel well, I'm not dying, so I need to go to the ER. But I wish someone could come over here and just do a quick 12 lead.
Yeah.
Just do a quick ultrasound. Take a look in my ear. What do you see in there? Because I can't look in there. And it doesn't have to be a physician. It could be a physician extender. It can be a paramedic. It can be someone else. And so this is where the value add is tremendous. Now, yes, we communicate back to their primary care doctor. We'll send an EPCR report, or we'll make a phone call. Every patient's different on how they want that interface to be. Some are saying, hey, no, we're good. Just give me the info. I'll feed it to my doctor. Some say, no, I want you liaising with cardiology, oncology, radiology, everybody. It just depends. And so we've got different collaborative approaches. It's really completely customized. So it's a lot of white glove, a lot of healthcare navigation. So we look at paramedics, we're at this crossroads of public health, healthcare, emergency management, and public safety, right? All of that coming together. So we are truly paramedics, truly, I would argue, are by far the most multidisciplinary, interdisciplinary public safety professionals out there, because you're dabbling in all of this.
Yeah.
This model and the privately led model allows us, because we're not 911 based, we don't fall under a system that's fire departments here, emergency management's here. You can't solve emergencies for patients as a paramedic in a 911 system. We can, because we are that patient's private emergency service, but we're not replacing public emergency management. We're handling these micro emergencies that the government doesn't, because the government's public facing, public based. So if you're a public service and you're dealing with the emergencies of a community, that does not absolve the need of having to address the micro emergencies that happen within. And we lose sight of that. Public safety is public facing, but what about the individual? What about their emergency? What about when it's you and you are by yourself with 3 kids at home and your spouse is having a heart attack? How do you manage the 3 kids? What if someone could come to your house, medically escort with 911, that patient, be their health advocate while you're back with the kids taking care of the home front?
Wow. Okay, that's really powerful. Man, that is great. I can see the value in that completely. So I'm going through the student questions that I shared with you, and you've covered a lot of them already. So is your service just based like in Northern Virginia? I mean, if they're traveling internationally, they're in Paris and they don't feel well, they've
Yeah.
got to do something else, correct?
Yeah. Well, yes and no. Yes and no.
Okay.
And so this is a very complicated thing. So this goes back to practical, legal, there's a balance, right? We have to follow the rule of law out the door, right out the gate. You gotta follow the rule of law. You gotta be licensed. You gotta be insured. You have to be properly registered, properly trained. The infrastructure has to be there. Okay. There's no that's just how to operate above board. When we go overseas to another country, we are not medical professionals because those countries are sovereign. Now you'll see people doing it. You'll see, oh yeah, I can send a doctor from Nevada to California. State to state, well, kind of getting kind of gray there. Oh, we're going to go now to Singapore. You know, so when we travel, we can do we call medical escorts, but then also travel assistance. What
Okay.
we like to do before the trip, preventive and protective. We like to get to know the patient's history, make sure that we look at all the medical risks, do maybe an MTA, medical threat assessment, evaluate what are the true risks of this patient being globally, being international.
Mhm.
It's not just identifying in country somewhere the medical infrastructure that's there. It's also having the medical capabilities of getting back to home country, but then being able to identify and stabilize in the patient while you're where you are from a Good Samaritan perspective or however you want to look at it. So we can go with patients and with clients overseas, but we're a travel assistant, we're a healthcare navigator. We are not practicing medicine in those countries. So it's identifying, establishing in-country partnerships with trusted medical professionals, which
All
is
right.
is a very, very complicated, area. It's not just if they don't have the money to do that, then simply we can identify what public resources there would be to coordinate, to the communications with whoever we have to call, wherever we're going to be. But preemptively, we like to get to know the patient, make sure they have the right medications going out the door. We
Mhm.
will write prophylactically for antibiotics and for EpiPens and stuff so they have with them their own personalized medical um, pharmacy, right? Rather, right? You're not bringing with you, sort of cardiac monitor, not bringing necessarily some of the medical equipment because you can't do those skills overseas,
Okay. Yeah.
right? So what we do, and I did a lot of travel recently in November and December to Israel and to I was in South Korea and other places. And again, you source in country, you help the patient navigate. What we always can do as Good Samaritans, no matter where we are in the world, the best of EMS is not always the best in treatment, it's the best in assessment. So if you are a great assessor, you can assess the signs and symptoms, the medical history, this patient may be predisposed to cardiac dysrhythmias. Bring a pulse oximeter. Bring something where you may be able to detect AFib. Bring an AED. Those can go anywhere overseas in any other country. The layman person, the lay stuff that you can bring with you. You can get ahead of it and you can help identify or have a real high index of suspicion of what you're looking for when you're in country. Also looking what's endemic in those countries. What
Yeah.
vaccines do we need to have? What's most likely to occur? Is it trauma? Is it medical? Is it kidnapping? I mean, whatever it might be, you have to build the medical capabilities around the potential threats and vulnerabilities that are faced by your client or your patient. So, but the key is you can't practice medicine overseas without a license in those countries. And that's the thing that people forget. So,
That's great. You got a fascinating job. Oh my gosh, this is just amazing. Let's see. Answer that. Okay, so one of the questions was uh, in a in a disaster situation, we've got private firefighters, well, like in Palisade, the private firefighters taking care of the protected properties. So the question, two questions from the students. Uh, what if your clients are in the disaster area? Do you provide medical evacuation?
we could,
Okay.
so remember this. This is one of the key things that most people don't realize about public safety. It's a duty to act, right? There's no duty to protect. And this is something that folks don't understand. The community does not understand it. The media does not understand it. There's a perception. You put on a badge, you put on a uniform. It's your job to go into the fire. It's your job to take a bullet. It's your job to get punched in the face. It's your job to get hurt. So when those things happen, it's your job, no sympathy. Not true. Not true at all. It's the job of the firefighter to respond to the fire, to identify the fire, and to effectively put the fire out. It's not the job of the responder, of the firefighter, to necessarily go into the house when it's on fire, to risk their life, to save someone. That's a risk decision that they can make. They can refuse it from OSHA standards. They can say, nope, not going in, too dangerous. Or they can say, I'm going in. I understand the situation. I understand this is ultra hazardous. I'm making the decision. The same thing for EMS when they put on ballistic gear and go into an active shooter situation. The same thing for a police officer who decides at a school shooting to make entry when they're not a SWAT team operator.
Mhm.
Those are choices that are above and beyond the requirements of the occupation, and they're above and beyond. They are not required to protect. They're required to act. So on the private sector side, as a protection agency, gets a little bit different, right? We're hired to protect. Now there are public. Let me pause here. There are agencies that do protect. The DSS, State Department, Diplomatic Security Service, U.S. Secret Service, the Pentagon Force Protection Agency, Federal Protective Services. They all have protection in their mission. They all have protection in their. So that's a little bit different. They are trained to protect, but law enforcement, public safety, sheriff's office, they're not. Police 911, police department, ambulances and stuff, they don't have to. They can sit back and watch your house burn or watch you get beat up. They don't have to stop it. It's not their job to stop it. It's their job to treat and to effectively either arrest someone or treat the medical emergency on the back end. So a private client is facing an emergency. There's no law that says we cannot go in and help them address the emergency. That would be crazy if there were laws to say, no, you can't go in and put that fire out. Only they can. Now, there are laws about who can run incident command.
Yeah.
And there are laws on, but that doesn't mean that the layperson or the private entity can't go in to effectively try to save human life or to prevent suffering or to minimize suffering. And laws that would be restrictive of those natures are places that you probably should not live.
Okay. I like that. That's great. Let's see.
So the answer is yes. We could go into those areas and we could do a medical extract. We could do the protection of those properties. We could physically remove them. We could. There's really no it's limitless on what you can do to protect someone. The question would be this: if someone was having an emergency right in front of you, to what end would you go to save them? A car's on top of them, their house, the car's on fire. It's about proximity now. But now that car is 10 feet away, 20 feet away, 30 feet away, 10 miles away. At what point is there an expectation of that you should go help them?
Yeah.
And there's been situations that I've been in where I've had to make these decisions, real time, where it's like, if it's right in front of me, sure, I'm going to do it, but maybe it's like a minute drive. Am I self-responding here? But guess what? If no one else is there and no one else is going, who's to say why you can't go save someone's life? It's not like you're just jumping on 911 calls and chasing people. That's not what we're talking about here. We're talking about someone's dying, someone's having a life-threatening emergency. You know it. You're the only one there to fix it. Go fix it.
Cool. So in terms of looking at your industry, is it going to continue to grow as you meet these needs and fill these gaps? Do you anticipate more and more opportunities?
Well, it was very interesting. We did a research on who's doing PSS EMS, who's doing protective security services and EMS services. And there are tons of private security companies that hire paramedics, but they're not EMS agencies.
Uh-huh.
What do we call that? Practicing medicine without a license.
Yeah.
Right. I mean, just bottom line what it is. Now, in some states, you don't have to be an EMS agency. Some states you can have a medical director that has a PLLC and they can link up the doctor to the paramedic, and they can operate. They're not an EMS agency. They cannot run lights and siren. They cannot do a lot of the things that we can do as an EMS agency. Okay. So that does it. So the market analysis demonstrated that there were none. There were protective security services that were working with EMS agencies. The problem with that is they're predominantly IFT. IFT paramedics can be great at what they do with interfacility transport, especially critical care, but they're not doing this sort of medicine. They're not doing the stay and play. They're not doing the white glove travel. They're not doing this part of it. It's not that they couldn't. It's just that's not where their expertise or training is, right? And so I definitely see the growth here. I definitely, especially on the concierge side, because why not? Why can't people have their own private access service to take care of them? We've seen a huge growth in concierge medicine since COVID. Just an explosion of concierge medicine. Well, why is that? It's not because people don't like their doctors, because they don't get enough time with their doctors. They don't like the fact that the access is maybe it's delayed. It's not what they would expect. It's not what they need. And so concierge, medicine is just blown up. Well, why can't they have that same thing with a concierge paramedic? And
That's
so
great.
why can't they have the practices working together and have enhanced access to, or alternate access to enhanced services? The question is they can. And where patients, and I think where the gap is in the market where people don't understand is like, well, but I have to pay for that. Well, guess what? Whether you have insurance or not, you're paying for it in a different ways.
Yeah.
It's these high deductible bills. People use insurance as health protection when insurance is designed as financial protection, right?
Okay.
So people will say, well, I want to spend $30 at this doctor because it's part of my copay. I won't spend $100 at this other doctor where I know I'm going to get better care. I'll take the degradation in care for 30 bucks.
Nah.
Well, why would you do that, right? Health insurance is not meant to protect you. In fact, health insurance can limit you on what you access and you can still access care that's beyond the insurance. It doesn't have to break the bank. Insurance was for those $30,000 hip replacements and for those $40,000 hospitalizations. That's what insurance is for. It's not for the urgent and emergent care. I mean, an ER visit 60 years ago was $8. The first ER, right? Now you're going to spend $1,200 just for the physician's consult, right? And then the nurses there, and then the hospital labs. You're going to have 4 different bills coming to your house from radiology, from nursing, from the hospital facilities, and from the doctor. And you're going to spend probably $4,000 or $5,000 for a typical ER visit.
Mm-hmm.
$8 60 years ago.
Yeah.
The question is why? Because that is the highest cost way to access healthcare, and it doesn't have to be. A gram of ceftriaxone, for example, can cost $500 in some places. Do you know how much it costs if I go online right now and buy it? About $4.99. And that's to pass through to the patient. So if you have a high deductible, even a low deductible plan, let's say your co-insurance costs $3,000 or $10,000. On our concierge model, most concierge practices around $3,000 to $4,000 a year. Some around $1,500 to $2,000 a year. Ours is $1,500 for 24/7 access to our providers. $1,500 a year, and then we do an hourly. So like $150 for a practitioner to go out the door per hour,
Okay.
right? So you sign up for our services. You spend $1,500 and you call us twice in a year. And say you spend $250 each time at maximum because we're there for a hot minute. So you spend $2,000. Calling us twice, preventing 2 trips to the ER, right? Or you go to the ER once and you spend $3,000 or $4,000 in your co-insurance. And you spent 8 hours in the ER waiting. You're around other people who are sick. You had to leave your house. The financial part there, it does make sense. It's just folks don't want to spend $5 on their health care. When you go out and buy a Maserati or a BMW or a Honda, the insurance company's not buying the car for you. They're insuring the car for you. The same thing with health insurance. You want to go out and you want to invest in your health and invest in your health protection, you got to put a little bit of skin in the game and then let health insurance take care of fixing the things that are financially crazy on the back end because healthcare is crazy expensive and doesn't have to be.
Wow. That's great. So my last question, this is my question, being an old Virginian. How difficult was it to establish a private EMS agency in the Commonwealth of Virginia?
Virginia is fantastic. I will say, as much as folks will there's a lot going on in Virginia now at the state level with EMS and a lot of controversy and a lot of there's a lot of great people working in the state and Virginia is fantastic about one thing I really love about it is it allows the medical directors to really drive the ship. Okay, DC is very similar. In this, and there are states that we cannot operate as an EMS agency. We can go into and bring patients out, and I'll say there are states where we really want to go. We want to bring these services to them, but they are under statewide protocol.
Oh yeah.
And so a statewide protocol limits the ability of a private EMS agency. I'm not talking about mom and pop. I'm gonna run out to 911 call and jump on and chase ambulance. I'm not talking about that. I'm talking about a professionally run EMS agency, right? There are in some states in our neighboring states, they don't have the licensure mechanisms to allow a company like ours to come in and establish a footprint. It requires us to either do IFT and then, which means we have to be submissive to CMS, the Medicaid, or we've got to be attached to a 911 service. And I'll tell you, there's 2 reasons for that. One, for control. They want the control. the operational medical control. And the second part is money. The local jurisdictions, there's an argument being made in some states that if a company like ours comes in, they're going to take the call volume. They're going to take the money from the 911 call. Well, here's the news flash here. If you go to someone's house as a 911 ambulance service who has a lacerated finger and you transport them to the ER, you are doing them a great disservice. Yes, you're billing for the transport. You sure are. But you are then putting them in a financial situation where they're paying for that through their insurance or out of pocket. And then they're paying way more for the ER. When that patient could have gone in a private vehicle and driven to an urgent care. Right? So not only are you doing a disservice, you're doing it for economic motivation. And that's not why public EMS should be in service. Yeah. Public EMS should not be competing with private EMS because of fear of loss of fund regeneration and funding because they can't run a 911 call because someone was prevented from having to go to the ER. That is the exact opposite of public health. It is the exact opposite of what we signed up for in emergency services, to force a transport because you want a bill for it to maintain the lights. That's not why we do emergency medicine. Yeah. And there are states that that's how they operate. And you can look and see where we operate and where we are not licensed, and you can put two and two together and figure out who's doing that. So
cool. This has been a fascinating discussion. I really appreciate you spending time with us today, because I'll post this for this semester. Also, if it's okay with you, I'm gonna use this for next semester's course, because you really do a great job describing what you're doing, and better than I could do, but if that's okay.
Absolutely. But our pleasure. So
thank you so much for your time. I appreciate it. You have a great day.
Thank you. Take care, Mike.
All right. Bye-bye.